Good afternoon. Good morning, everyone. Bonjour tout le monde. Dr. Tam is appearing before the House of Commons Standing Committee on Government Operations and Estimates alongside the Minister of Health today, and therefore I will be providing the update alone. As usual, I will start with the latest numbers on COVID-19 in Canada. There are now 81,765 confirmed cases, including 6,180 deaths, and 41,986, or 51% of cases, have now recovered. Labs across Canada have tested over 1,401,000 people for COVID-19 to date, with about 5% of these testing positive overall. We are now testing an average of 26,000 to 28,000 people daily. These numbers change quickly and are updated regularly on canada.ca/coronavirus. Puisque c'est vendredi aujourd'hui et que nous sommes nombreux à avoir hâte à la fin de semaine, moi aussi, je tiens à profiter de l'occasion pour rappeler à tous de continuer à suivre les mesures de santé publique individuelles qui sont importantes pour arrêter la propagation de la COVID-19. Comme on allège les restrictions d'un bout à l'autre du pays, les Canadiens sont bien que je partage ces sentiments, je vous recommande tous fortement de ne pas oublier que les prévisions optimistes seront tributaires de notre application continue des mesures de santé publique. Certaines personnes sont toujours susceptibles d'être gravement malades de la COVID-19. Il ne faut donc pas sous-estimer la gravité de la situation. Il est extrêmement important de continuer à pratiquer la distanciation physique et à se laver les mains fréquemment. Veuillez le rappeler à vos enfants et montrer l'exemple à votre famille et vos amis. Les autorités de santé publique de votre région formuleront leurs recommandations en fonction d'un certain nombre de facteurs, notamment les taux d'infection et de transmission dans la communauté. Il se peut donc que ces recommandations varient d'un endroit à l'autre selon l'état de la situation à l'échelle locale. Since today is also a Friday, and many are looking forward to the weekend, myself included, I want to take this opportunity to remind everyone to continue following the individual public health measures that are important to stop the spread of COVID-19. Restrictions are easing up across the country, and Canadians are feeling excited and optimistic. And while I share those feelings, I urge you all to remember that any optimism is predicated on our continued adherence to public health measures. There are still people at risk of becoming very sick from COVID-19, so this is not a time to become complacent. It is extremely important to continue physical distancing and washing your hands frequently. Please remind your kids and be the example for your family and your friends. Public health officials in your area will make recommendations based on a number of factors, including the rates of infection and/or transmission in the community. Recommendations may vary from location to location based on local reality. Also, remember it is now recommended that Canadians wear a non-medical mask as another layer of protection for settings where physical distancing is not possible. Changed our world. It's made things we once considered straightforward much more complex and will likely continue to do so for the foreseeable future. Living with COVID-19 means going out smartly, protecting yourself and others. This weekend, remember to wash your hands frequently, keep a safe distance, and stay home if you're sick. Thank you very much. Merci beaucoup.
Thank you, Dr. New. We will now open the floor to questions. Vous pouvez poser vos questions dans l'une des deux langues officielles. We ask that you limit yourself to only one question and one follow-up. For those asking a question in the room, we do ask that you make your way over to the freestanding mics. Julie, over to you.
Julie Van Dusen, CBC. We've seen the numbers spike in Ontario in the last 24 hours. There seems to be concern about where it is that people are getting infected. Can you take a shot at that?
Well, certainly the situation across Canada varies from region to region. I would say that overall, and I would thank Canadians across the country for all their efforts, because I think as a whole, we've succeeded in flattening the curve. We haven't overloaded our hospital care system, and I think we're well positioned should any individual fall sick with COVID-19 and should they need more intensive care, that they are able to access that care in a hospital. Having said that, we also recognize that the situation and cases vary across the country. So I would say that many provinces right now, especially let's say in the north, the territories and also the Atlantic provinces, for example, they're very few cases, relatively speaking. And I think they're in a better position to be able to jump on, I say, those cases in a very rapid fashion and make sure that they do the appropriate contact tracing. I would say at this time, the hotspots in Canada really are, I think, the two biggest provinces, Ontario and Quebec, and more specifically, I think the Greater Toronto area and also the Montreal area. And I think that that's evident for everyone. And I think in large part, some of the challenges relate to the fact that there's a higher population density. And then with that, obviously, it's more of, I think, a challenge in some ways to make sure that you can quickly identify the cases and then do the contact tracing. But the principles in public health have remained the same throughout the country. The hopefully rapid detection of cases, making sure that they're isolated and managed appropriately, and then contact tracing, which everyone knows now, is to quickly identify who that initial case might have been in contact with, and then making sure that they're appropriately managed as well. In that regard, I'll expand on that. As our Prime Minister has said, the federal government is certainly ready to support the provinces and territories with what we call maybe a national testing and contact tracing strategy. I know that our Prime Minister met with our First Ministers yesterday and certainly agreed upon the principles of what that strategy would entail. I think from the federal perspective, we're always there to support the provinces and territories. And if you were to look at the two aspects, maybe I'll unpack that a bit. In terms of testing, as you've seen since the beginning, the federal government has always been there to support the provinces and territories in anything that's related to making sure that the capacity is there. So first of all, in the beginning, there were issues, and I think we've managed well in terms of making sure that there's the right equipment in the provinces and territories, be it the availability of laboratory reagents, making sure that we have enough swabs, etc. So from a testing perspective, that's now in place, and certainly the provinces and territories, their laboratory capacity has steadily increased, and I think it's a very good place right now. So with that, in terms of the capacity for testing, we're talking what we call the PCR based test, the molecular testing, which obviously is used to test people who we suspect of having COVID-19. The other two elements in play that are obviously under development right now as we speak is what we call the rapid or point of care testing. And certainly people can appreciate that with the current testing, it still requires taking what we call, an NP swab, nasopharyngeal swab, then taking the sample and then transporting it to a laboratory to get analyzed and so on. And the turnaround can be, in a number of days. For the point of care testing, obviously for management of the suspected case and then the contacts, it's obviously ideal to have that result in a much quicker time. And certainly we can see that the first application, once we're able to roll that technology out across the country as appropriate, would be, I think, prioritized for what we call remote and isolated communities. Because right now they have those challenges in which if there is a sample taken, it takes quite a bit of time to get it onto an airplane, maybe, and send it down to a laboratory down south. So that's certainly one type of setting in which that type of new technology would certainly be of benefit, and then possibly in other settings down the road, for example, long-term care facilities. So that's it in terms of those two test modalities. And then the third one, as we're all talking about now, is serological testing. And that one is slightly different because with serological testing, what you're actually doing is testing antibodies. As you can see, obviously, there's a delay because it's not going to detect someone right away when they get the infection, but obviously several days later when the body is able to mount an immune response and develop the antibodies. And so the actual application of that type of test would be slightly different, I would say, compared to what the molecular test is intended to do. We've talked about the Immunity Task Force, and that type of test, I think, would be of great use as we do what we call seroprevalence surveys to get a better idea of how the virus has propagated, where it is within the population at large, maybe even specific age groups or specific populations at risk. And that would help us in terms of modifying or adjusting public health measures as needed moving forward. So that's sort of the three types of technology that is now in play. And then, of course, what's also evolved in terms of the testing is the actual indications. If people can remember, I think at the beginning of all this, we had very few cases. And so based on what we knew at the time, we said, okay, if everyone who maybe has traveled or been to Wuhan, China, as a returning traveler back to Canada, and if you have symptoms such as, a cough, a fever, shortness of breath, then definitely you should see your doctor and maybe get a test. As obviously the pandemic has evolved and now we know much more in terms of the range of symptoms, we've also updated our guidance. And as I mentioned, I think a few days ago, the guidance has been approved by the Special Advisory Committee. I think it might still be a few days or so before we actually make it public in terms of putting it out into our website. But certainly all of the health officials across the country are well advised, and they've also obviously been part of to develop the criteria. So the first important part of that is that in terms of testing people, we've obviously enlarged sort of the group of people to be tested. Before, as I mentioned, it was really based on a few symptoms. Now, with the wide range of symptoms we've seen, anything from general malaise or to headaches and so on, I think we're basically empowering physicians to basically have a very, high index of suspicion in terms of clinical judgment. And should they see any patient that has any symptom or feeling off, that there should be consideration of doing a test for COVID-19. So that's one of the ways that we're hopefully improving sort of our testing rates by testing the right people, as they say, at the right time in the right place. In addition to that, in terms of our guidance, we've also indicated and agreed that there are certain what we call high-risk asymptomatic individuals that also should be tested. For example, if you do find a case in a setting like a long-term care facility, there's an outbreak, then it would make sense, based on local context, to then maybe test all of the other residents or the personnel within that establishment. So you can see those are the kinds of revisions or updating of the guidance for testing that we've put out to our counterparts, our colleagues across the country. So that's it in terms of the equipment and the testing. And then, of course, what's also very key as part of an overall strategy is the data. So for planning purposes, to actually better manage the situation outbreak at a local level, it's very important to have what we call timely data. And that is one of the issues that is under what we call active discussion. We do recognize right now that the provinces and territories each have their own systems, their own databases, the way they collect data and so on. And I think there is room for improvement in terms of maybe coming to agreement in terms of be it common platforms, standardized ways to collect and transmit the data so that in a quick turnaround, you could have it coming from local level to the provincial level and then also to the federal level. So we can do those analyses and then, collectively, but also at the appropriate local level, undertake and do the public health activities as appropriate. So that's another part of the overall strategy. And then finally, the third part, contact tracing. I think that's something that many people now are well versed in, recognizing that it's not just a matter of identifying the case and then making sure that person is appropriately managed and treated, isolated, but also making sure that you identify the context who that person might have been in contact with and might have possibly exposed and also infected. And so you can appreciate that's very what we call labor intensive. It takes sometimes an army of a contact, and certainly in that respect, the federal government is offering. We have a pool of what we call trained people that can go out and do the contact tracing upon request from the provinces and territories. So that's another additional support that the federal government is putting forward. And in addition to that, certainly we're prepared to give the training, but recognizing that the demands or what's required at a local level may vary. Certainly we want to make sure that when these people are requested by the provinces and territories, that they're able to hit the ground running, as they say, that they don't need sort of additional training and in essence being a burden for the first few days on the ground. So those are the logistics and so on that need to be obviously put in place so that they can be effective and efficient when they do go to the local level. And then finally, in terms of contact tracing, another part that we're actively looking at is what use could technology play? And people have all heard about various contact tracing apps. There are different ones out there. Certainly, we're looking at examining the pros and cons, how effective any of these given apps are. And I think from a public health perspective, we're also very cognizant that there's one thing to look at, quote, the public health objectives in terms of contact tracing, using all sorts of tools within smartphones, be it GPS, et cetera. But we also recognize there's a balance and that we need to take into careful consideration, obviously, the privacy issues and concerns. So those are all of the things in play. And as you can see, lots of moving pieces, but as a whole, they make up our overall strategy.
Okay. I don't remember what my question was, but that was a very comprehensive answer.
Okay,
I
so
know that much. Let me ask you this. It's very topical. The House coming back next week. They're trying to figure out how to do it. One party is suggesting having 50 MPs as opposed to the 30-something that are there now in person. Do you think that's safe?
From a public health perspective, it's not for me to comment in terms of how the House will actually function in terms of the logistics of how many people might be sitting. Certainly what we've given to all the parliamentarians and the government is the public health advice, so that the principles, be it for the general population, is the same for parliamentarians. You know, the three main things we always talk about is, first of all, physical distancing, you know, the 2 meters. So if you can somehow figure out the logistics to maintain that 2-meter physical distancing, that's key. The other part also is hand washing, good personal hygiene. So in addition to hand washing with soap and water, I see all over the place now, these dispensers, the hand sanitizer. So certainly that's something else that I think parliamentarians should avail themselves of. And then finally, obviously, we're telling everyone, so that would include parliamentarians, if you feel off, if you feel sick, don't come to work that day. So with those sort of three basic principles in place, we'll leave it to the parliamentarians, the logisticians, to figure out the best way to make Parliament function.
Great. Thanks, Julie. Glenn?
Glenn McGregor, CTV News. Doctor, I just want to follow up on Julie's question about Ontario. When you look at the curve, so far it goes up, it's kind of turning back upwards. Doesn't look wildly different than the curve from the 1918 Spanish flu. I'm wondering, do you think we are now into a second wave of infections? And is it possible that that second wave starts before the first wave, the curve of the first wave has been flattened?
That's a difficult question to answer at this point, because obviously you can only really determine if you have to quote that second wave in retrospect after hopefully that first wave has ended and hopefully have that sort of a trough for a period of time. I would say at the present time that what might be happening in a local area might just be, to say, that usual fluctuation and blips. And so it's too early to say whether it's really an upswing or something that hopefully, if the data shows that there is an upswing in cases, that they're able to get on it, identify those cases and do the appropriate management of the case as well as the contacts. I think in a general sense, that people talking about the second wave, I would say there's two parts in terms of what we might be looking across Canada. Certainly with our short summer, I think all of us are looking forward to getting outdoors. And I think what some of the scientific evidence is showing is that there's a greater risk in terms of people congregating indoors as opposed to being outdoors. So in a general sense, it's safer to be outdoors, of course, respecting physical distancing and so on. So I would certainly encourage people that as much as you can, get outdoors, enjoy the fresh air. I think the sun and fresh air will do a lot of people a lot of good with physical activity and so on. So if that's the case, then what we anticipate is that we might be okay for the summer if that was the only thing in play. Unfortunately, the other part of it is that as people go out and start enjoying the summer, people also tend to become complacent and maybe forget that they have to maintain all of these public health measures, because at the end of the day, it's not the government, it's not the healthcare system, it's the average Canadian and how well each person understands and feels their own personal responsibility to not protect just themselves, but protect others. Of a second wave, what we're planning for in many ways is anticipating that as the fall comes in and we get back into what we call respiratory infection season with our winter, including seasonal flu, that's what we have to plan for and be careful about, because in many ways during a regular flu season, there's quite, depending on how bad it is, you have quite a number of people accessing healthcare, going to the hospitals and so on, with many of the same symptoms that we now know are with COVID-19. So as much as we can manage sort of a COVID-19 as well as respiratory infections in general for, quote, that potential second wave, then that's what we're obviously looking to do.
Okay. You mentioned earlier the changing indications as a requirement for testing and how that's evolved. When do you think we're going to get to the point where all provinces start doing routine surveillance testing of people who are not necessarily symptomatic? And I'm also wondering how you get that sample to be representative of the community. Alberta last week opened up testing to asymptomatic people in Calgary, and they had far fewer people come forward, I think, than they were anticipating. They were expecting 1,000 a day. So I'm wondering, how do you get to the point where you're doing surveillance testing in the community to get a true picture of the degree of infection right across the entire community? And is it being considered that you make that testing mandatory in instances, that it isn't voluntary, so you get a more representative picture?
Okay, that's a very good question. I would say that there's two parts of that. So first of all, in terms of the criteria for what we call the PCR molecular testing, it's interesting because, as you say, we changed the criteria where maybe someone several weeks ago might have actually had what we might consider classic COVID-19 symptoms, a fever, a cough, shortness of breath, and so on. But because there maybe just wasn't the capacity, the healthcare system maybe where they were living at the time was maybe, quote, a bit overloaded, that they were told, okay, from a pure public health and case management point of view, the best thing for you to do is just stay home and ride it out and don't expose anyone else. Now that we know more about it and the testing capacity has gone up, and we want to really, really flatten the curve, the criteria have been loosened. And one of the things, besides giving, physicians and the healthcare system further sort of flexibility to test people, it's also encouraging the general population. I think many people still remember maybe a month or so ago, and they say, oh yeah, my neighbor was really sick, but they couldn't even get a test. So I'm feeling a bit off today. I've got a headache and a crummy, and I have a muscle aches. That's not even worth seeing a doctor. I probably won't get in. I won't get a test. Now we're saying yes. It is important, because if we really want to get a handle on what the situation is, to your point, that we need to start testing people with milder symptoms who maybe before we wouldn't have thought had COVID-19, but now we actually, through experience and some of the data showing us that they actually do have COVID-19. So that's one point in terms of encouraging people to come forward for testing. In terms of asymptomatic individuals, as I mentioned before, I think the priority should be testing asymptomatic individuals in which it really is a high-risk setting, in which you might actually have severe consequences if you are not able to detect those individuals. So I mentioned long-term care facilities. I can imagine other settings, for example, in a homeless shelter or maybe a meatpacking plant and so on. So definitely those settings, it would be appropriate if there were a number of cases, an outbreak, to maybe test the rest of the personnel or the residents in the establishment as appropriate. More general testing in terms of asymptomatic individuals, it depends where you go. It depends on the level of community transmission, because not to get to all of the details, if you test a large group of individuals in which actually the prevalence or the actual virus is not really transmitting, because there's no test that's 100% perfect, what you're going to end up getting is probably a lot of what we call false positives, which also is, in a sense, sort of not the best use of resources, but also requires additional resources to manage those people who then ultimately turn out not to even have COVID-19. So in that sense, what we're asking the provinces and territories, and they're also doing, is what we call maybe pilot studies, surveillance studies, as the one you mentioned in Alberta, where they're asking people if they're coming to a clinic and they're maybe not really feeling that ill, maybe they have a few symptoms or not, that it might be worthwhile to get a COVID-19 test. So that's how we're looking at it right now, not sort of mass testing of the whole population, but maybe pilot studies, maybe in hot zones in certain areas of certain cities where there's a lot of transmission going on. And then the other way in which we may also get a better idea of what's happening in the population as a whole is the serological testing. With the researchers going out across the country and testing, obviously, volunteers to go for serological testing and seeing if they actually have antibodies, we might discover there are many people who were totally unaware that they were even infected and had COVID-19 infection, but the antibodies will show that they truly had infection. And that will give us all collectively a better idea of what's been happening, maybe with respect to transmission across the country or certain regions, prepare for and plan for the next potential wave.
Thank you. Global News.
Well, hello, Dr. New. I just want to get my head around this. We talked about the 60,000 capacity the other day. So we're increasing the amount of the criteria for testing. People have headaches or they're feeling sort of sick. So now that we have that capacity, we can do that. Is that what you're saying? Is this because we have that capacity now,
Yes.
we can test the milder cases?
Yes. The 60,000 was based on, obviously, discussions with the provinces and territories and what they have in terms of the laboratory. So we say laboratory capacity, that's actually the ability of the laboratories to analyze on sort of, let's say, a daily basis, that number of samples per day. But as you say, you can lead a horse to water. And so now maybe part of the issue is that with the nicer weather, people getting out there, and maybe less people having symptoms, that it's also a matter of encouraging people, if you are feeling ill, that you should seek medical attention and get the test, because that way we'll have even a better idea of what's happening with respect to COVID-19 transmission across the country. So it's both giving the flexibility to physicians, but also encouraging people, not just go because we're telling you to, but obviously if you're feeling ill enough or just off in any way, I think it's important to seek medical attention. So with that, certainly based on the number of tests we're doing, 30,000, that's just 50% of that, quote, overall lab capacity. Part of the challenge may be, and I can't speak because I don't really know what's happening really, as you say, on the ground, is that even if the laboratories are able to process the samples, it's actually getting the people to the test sites, getting the samples, and then transporting the samples to the laboratory. And so I know that in places such as Montreal, they're looking at innovative ways like having mobile vans at testing sites to actually get out there to the communities where there is a lot of transmission and encouraging the individuals who could or should be tested to actually go and get the test. Then they can get the actual sample and send it to the laboratory to get tested.
Thank you.
Thank you. And your follow-up?
I do have a question about the serologic stuff. We were talking about, like we see in other countries, they have tried it, and it hasn't exactly gone as well as they expected. How are we doing, and when can we expect to, or is there any, what's an update on how our serologic testing is going, and are we any closer to rolling that out?
Well, I would say in Canada, I think we have what we call a very good regulatory regime. And so with Health Canada, they took, in terms of ensuring that the quality or sort of the how you say it, the validity of whatever approved test, which they finally approved for serological testing, is there. So I think we have more confidence in Canada that the testing, we start doing the serological testing and the prevalence surveys across the country, we won't get into the same situation and problems that they had with other countries with, with sort of, false results. So in that sense, I think with the testing technology, I think that's well in hand. As far as rolling it out, certainly the Immunity Task Force is actively meeting, and they're having those active discussions in terms of how they want to go out there in terms of all of the types of research questions out there. Which groups could or should we be testing? What parts of the country? Are there specific age groups and so on that we would want to target in terms of doing those surveys? So I would say, I anticipate that in the coming weeks and months that will become, say, more public, and they'll actually be rolling out those surveys and testing.
Thank you, Dr. New. Operator, we'll turn over to the line for the next question.
Thank you. Merci. Please press star 1 on your telephone keypad if you would like to ask a question. Veuillez appuyer sur étoile 1 si vous désirez poser une question. Our first question, notre première question, is from Lena Dib avec la presse canadienne. Please go ahead. À vous la parole.
Oui, bonjour Dr. New. J'ai une question sur le partage de données. J'aimerais avoir votre évaluation de scientifique sur la qualité des données qui sont maintenant ramassées dans chacune des provinces et sur votre capacité vraiment de les comparer. Est-ce que ce sont des données comparables ou est-ce que ce sont des données qui donnent de l'information trop différente pour être toutes mises en commun?
Merci pour la question. Oui, moi, je peux constater que oui, c'est un enjeu actuel, les données. Ce qu'on voit à l'échelle fédérale, on continue à recevoir les rapports des données des provinces et territoires, mais on voit que, comme dire, les rapports plus détaillés, c'est seulement un certain pourcentage. Ça continue à être mieux, mais pour l'instant, c'est pas 100%. Et même, on sait que à l'échelle provinciale et territoriale, les données, ça prend du temps d'être transmis de l'échelle locale à l'échelle provinciale. Donc, c'est sûr que c'est quelque chose, on discute maintenant. On essaie de trouver une solution. Peut-être c'est au fur et à mesure, mais je pense que le rêve, si je parle pour la communauté de santé publique, c'est vraiment d'avoir un système bien intégré pour la surveillance aussi, pour les données. Mais à part de ça, je peux dire que la qualité des rapports qu'on reçoit actuellement, c'est bon parce que avec nos discussions avec nos homologues, on a des formulaires standards et les provinces et territoires, quand c'est possible, sont très, très bonnes, très bien pour remplir les formulaires et la qualité, c'est pas mal. Mais c'est sûr que c'est difficile des fois de voir comme des analyses très détaillées avec il y a toujours une certaine incertitude parce que on sait que les données ne sont pas comme au complet à 100%.
Votre suivi?
OK. Oui, alors, pouvez-vous m'expliquer, elle est où la difficulté d'avoir des analyses détaillées? Est-ce que c'est parce que vous n'avez pas assez d'informations qui vient des différentes provinces? Sur un cas, par exemple, l'âge, le lieu d'infection, etc., ou est-ce que c'est... J'ai perdu mon idée. Donc, est-ce que c'est ça qui vous manque, ou est-ce que les données vous arrivent pas assez vite, ou je comprends pas. Elle est où la difficulté d'analyse, ou est-ce que ce sont des données tout simplement pas comparables, parce que le Québec garde certaines données sur les malades, puis l'Alberta en garde d'autres.
Non, je pense qu'à travers le pays, la qualité des données, c'est pas mal, mais c'est ça, c'est le même enjeu qui existe actuellement que peut-être dans quelques régions, peut-être je prends par exemple Montréal, tout le personnel court actuellement pour gérer les cas, pour faire le retraçage des contacts. Donc, c'est aussi une autre tâche, un autre défi pour ramasser tous les données, l'information importante, pour remplir les formulaires, puis après transmettre l'information à l'échelle provinciale et aussi finalement à l'échelle fédérale. C'est pourquoi c'est un des offres que le gouvernement fédéral a fait. Le premier ministre a déjà constaté, oui, on est toujours prêt ici à l'échelle fédérale à supporter les provinces et territoires parce que si on peut aider les provinces et territoires avec le retraçage de contacts, une partie de ça, c'est aussi, on va aussi avoir peut-être les données de bonne qualité, mais aussi on peut recevoir plus vite parce que on a le personnel sur le train qui aussi sont prêts à aider les personnes déjà sur le train à faire le travail très, comment dire, je ne sais pas en français, labor intensive. Merci.
Merci, Doctor. Operator, next question on the line.
Thank you. Merci. Our next question, notre prochaine question vient de Salman Malik with CBC. Please go ahead. À vous la parole.
Thank you. This is a question about filters for homemade masks. Health Canada's website says that paper towels or disposable coffee filters can provide an increased benefit. Can you talk about what that benefit is and what kind of filters should we be using? Are there any materials that people should be staying away from?
That's a good question. I haven't personally been able to look at the website. I think that the whole area of sort of homemade mask, I think, is certainly continues to sort of evolve as to how different types of materials may be useful or not as useful in terms of helping to to protect others in terms of what the wearer uses in terms of these homemade masks. At this point, I personally am not able to give you a precise answer in terms of what you're asking in terms of filters or other types of material. I can just say that in principle, what we're recommending, and we can certainly provide more details later, is that homemade masks. There's different types of materials, but certainly one of the things that I was aware of is that a simple test in terms of determining whether it may be, I think, of at least a certain thickness of the transmission of, let's say, respiratory droplets from going through the mask is to use the sort of the window test. You know, if you can hold up the material of the mask and to a window, and with the sunshine outside, hopefully, and it's not translucent and it's pretty opaque, then you're pretty well assured that at least it will quote do the job in a general sense. And so if you were to then wear that mask in public, as we've said before, the purpose of homemade masks is not to protect yourself against others. It's really, in a sense, to protect others from what you may be maybe unwittingly, unknowingly transmitting if you were to maybe have mild symptoms or maybe be asymptomatic and maybe have a slight cough or be talking and sort of expressing what we call respiratory droplets. So I think the general point now is still that it's still a supplementary measure, and it's certainly we don't want to take away from the tried and true three main public health measures and messages we keep repeating, which is physical distancing of 2 meters, basically hand washing regularly, and then staying home if you're sick.
Mm-hmm.
Thank you so much.
Thank you. There's people have been using all sorts of materials for filters, and I'm just wondering if there are any precautions that we should be taking.
Well, certainly, I think with the homemade mask, I think the most important thing is that you have to make sure that it's also, appropriately fitting, because it really does no sort of good to anyone, including the wearer, if, let's say, there's large gaps and it's not sort of a nicely fitting, fitting to the contours of your face. Other than that, like I said, the actual materials, I think we're looking at, inert materials. So I'm not sure in terms of filters and so on. I just be careful. I'm just speculating now that if people are using various types of materials that might be, as I would say, have chemicals or et cetera on them, right? People might think, I'm just thinking out loud now, if they were somehow thinking that if you use certain materials or filters that were maybe impregnated with certain types of chemicals and so on, I would be very careful, because that in many ways could actually be a risk to the wearer, because they could be inhaling toxic, fumes or substances. So I think by keeping with inert materials at this point and not getting too complicated with all sorts of filters, I think that's the way to go for the present time. But certainly as we learn more and the science evolves, I'm sure lots of innovators and creative scientists will come up with different types of recommendations that also support sort of the making of homemade masks.
Thank you. Operator, next question on the line.
Thank you. Merci. Our next question, notre prochaine question is from Micheline Laflamme avec Radio-Canada. Please go ahead, à vous la parole.
Merci. Bonjour, Dr. New. Dites-moi, le premier ministre semblait indiquer qu'on serait sur le point d'avoir une application mobile pour suivre les gens et ceux qui sont infectés. Alors, dans quelles circonstances cette application-là fonctionnerait le mieux? Ou est-ce qu'il y a des régions, des provinces où vous croyez que ce serait très, très utile d'avoir une application comme celle-là?
Merci pour la question. Concernant les apps pour les smartphones, les choses mobiles, c'est un enjeu actuel. Comme le Premier ministre a constaté, on a des discussions même au sein du gouvernement fédéral, mais aussi avec les provinces et territoires, parce que tout le monde sait que c'est possible que les applications peuvent être un autre outil, quelque chose on peut utiliser, mais il faut bien assurer aussi qu'il y a un équilibre entre, atteindre les objectifs de santé publique, mais aussi à garder la vie privée, la confidentialité des personnes. Il y a aussi des autres enjeux que vous avez constaté que ce n'est pas clair comment les applications peuvent être utiles. Peut-être que c'est plus utile dans les circonstances, dans les grandes villes où il y a beaucoup de monde avec une plus haute densité de la population. Mais même avec les applications, des fois, c'est difficile parce que même si on utilise une application et il y a deux personnes peut-être avec une distance de moins de 2 mètres, mais c'est dans un magasin, il y a déjà une barrière de plexiglas. C'est pas la même chose, pas la même situation que deux personnes dans une autre circonstance où on ne peut pas garder une distance de 2 mètres. Donc, il y a toutes sortes des enjeux et il faut aussi considérer. Et finalement, je peux dire que on n'a pas vraiment décidé pour qu'est-ce qu'on fait pour une seule application ou peut-être avoir peut-être une gamme des applications. C'est quelque chose, on continue à avoir des discussions avec nos homologues des provinces et territoires. Merci.
Merci. Votre suivi?
Mais est-ce que, donc, dans ce cas-là, on peut parler d'une ou de plusieurs ou de pas du tout, mais s'il n'y en avait pas du tout, est-ce que ce serait comme manquer son coup? Est-ce que de ne pas avoir d'application du tout à travers le pays ferait en sorte qu'on manquerait des cas, qu'on passerait complètement?
Would that mean that we would actually overlook a number of cases across the country by failing to use these kinds of apps? Response. Well, listen, it is one tool in a toolbox, and we are monitoring it closely as technology evolves. Now, have smartphone apps helped with previous diseases? The principle is very simple. If there is a case of infection, that case needs to be identified as quickly as possible, isolated if necessary, and that individual's contacts have to be traced. There are phone calls made, and so on and so forth. You know, this kind of exposure notification app isn't going to be a silver bullet. It's there still has to be a kind of follow-up, you know, an interview with the individuals that were infected. Technology isn't going to save the day completely, if I could put it that way. Thank you.
The line for the last question.
Thank you. Merci. Our next question, notre prochaine question is from Jordan Press with the Canadian Press. Please go ahead. À vous la parole.
Dr. New, you talked a bit about trying to get people to actually go and take the test, and we can supposedly do 60,000 COVID-19 tests a day in this country, but we aren't. So is it simply a matter of just getting people to go take the tests, and would that reach the 60,000? Or if that's not the simple answer, could you maybe explain why in some simple to understand terms for those of us who don't have a medical degree?
Okay, thank you for the question. I know it's been interesting for me and Dr. Tam, this, I'm not sure, not in a bad way, this fixation with the 60,000. So what I can say is that the 60,000 is the ability for laboratories across the country on a daily basis to be able to process tests. But it's not a figure that we necessarily have to get to because of the disease in the country. So I'll give you a good example. In British Columbia, they seem to be doing a very good job in terms of flattening the curve, so to speak. There are now quite a fewer number of cases being reported every day. Also, fewer people are having symptoms, and therefore, in that situation, the Chief Medical Officer of Health, Dr. Bonnie Henry, has made it very clear. As we've said here at the national level, it's all about testing the right people at the right time in the right place. And so it's not just about getting people to go forward for the test. So we hit this magic number. One of it before is that, okay, the right people. Why do we say right people, right time? Okay, the way we can maybe best explain it is that if you truly are infected with COVID-19, and it's very early in what we call the incubation period after your infection. It may well be that the virus has not replicated enough, or you don't have enough of what we call a viral load, so that the test is not actually able to detect it. And then you will get what we call a negative result, or maybe what we call a false negative result. And so, based on the science and the evidence, what we've seen is that the ideal time to test someone is about maybe a week or so after they've actually been infected. But who knows? So really, the best time might be when they actually develop their symptoms, or even 1 to 2 days after the onset of symptoms. That's when the viral load is highest, and that's probably the best time for that person to be tested. So that's sort of two things at once in terms of people with symptoms, be they mild or severe, getting tested, and as we say, at the right time. If you just have people just going forward for testing when there's no indication, you might just get a whole bunch of what we call false positive results. And also, even people, if they truly were infected, if they rushed forward too quickly when they weren't really feeling that ill, they might not actually get the result that would lead to the appropriate management. So I'm not sure if that answers your question, but it's not that we have to hit a number. It's in many ways reassuring the Canadian population that the lab capacity is there, and that should there be maybe a future wave or an outbreak in any given part of the country, that the laboratory capability of analyzing the samples is there. It's still another thing to actually have the people go forward for the testing as appropriate, get the swabs, and then transport the samples to the laboratory for the analysis.
Thank you. And your follow-up, Jordan?
Yeah, thank you for that. I wanted to follow up with just slightly on the kind of the same track, but maybe slightly different, which is the Center for Disease Control has updated some of the wording on or some of the guidance on its website about how the virus spreads. And it says that it's not easily spread from touching potentially contaminated surfaces. So I'd just like to put it to you, sir. Can you just talk a bit about what Canada's knowledge is on how COVID-19 spreads, particularly when it comes to surfaces?
Yeah, well, I can say is that here in Canada, the United States, I think around the world, the scientific community, where we're all working very closely together, and so the evidence, the science out there is essentially similar throughout the world. And it's right, based on the studies to date, it has been shown that the virus can persist on surfaces up to several days for quite a period of time. And certainly they talk about, quote, harder or non-porous surfaces. The virus can survive for longer periods of time as opposed to what we call a porous material. Having said that, though, I think that what we understand is that the two main ways that the virus is spread is what we call direct person to person, and that talks about the respiratory droplets, and that's why we're talking about the physical distancing and maybe the use of face masks and so on. But in terms of the environmental aspect, yes, if someone were to, let's say, touch a contaminated surface and then quickly touch their face, it's certainly possible that they can become infected. And therefore, that's the other part of the public health messaging, is that wash your hands frequently. If you happen to touch a contaminated surface, that's fine. The virus may be on your hands, but if you're practicing good hand hygiene and not touching the most, vulnerable parts of your face, what we call the mucous membranes of your eyes, your nose, and your mouth, then the virus won't be introduced and you won't become infected with the virus. But having said that as well, many, businesses, and it's also recognized that environmental cleaning is also an important part of what we can do to reduce the possibility of people becoming contaminated with the virus. So, regular, more frequent cleaning of environmental surfaces like doorknobs and so on, that's all good. But there's also a limit, because what I can say is that even if you were to, let's say, have a great sort of environmental cleaning and the doorknobs are wiped off every hour, it only takes the person to come by the minute after that doorknob's been cleaned that somehow is contaminated and touching it and then contaminating and putting the virus on that doorknob. And then you come by two minutes later and then touch that same doorknob, that you might become contaminated. So environmental cleaning has a certain place, but I think the most important message is that just think of it, besides COVID-19, doorknobs and many surfaces, if you were to take a swab, there's all sorts of microorganisms, bacteria and viruses. And so the advice about hand washing, I think, obviously important for COVID-19, but I think, as your mother might have said before, wash your hands before you eat. That was good back in the day. It's still good today.
Great. Thank you, Dr. New. Thank you. That concludes today's press conference.